Testing. Is it good? Okay. I'm Ari Bernstein. I'm a pediatrician at Boston Children's Hospital. I'm the interim director of Harvard Sea Change, and I'm the assistant director of the Climate and Health Initiative at the Harvard Global Health Institute. And it's my honor to moderate our first panel. I'd like to invite our panelists to come up. I'm going to introduce them all at once and then let them deliver their remarks. We have 5 panelists representing 5 medical specialties from 5 different institutions. And as you heard earlier, we have representation here from a wide swath of the healthcare providers in Boston. So to start with, Gaurab Basu will be our first speaker. I'm going to give very short introductions. All of these folks have distinguished biographies, which you can find easily. But Gaurab is a primary care provider at Cambridge Health Alliance. I had the pleasure of meeting Gaurab probably almost a year ago now, and because he saw the relevance of climate change to his work as a primary care doc at Cambridge Health Alliance, and he'll be speaking to that. Lucy Marcil, who is right there, is a pediatrician. I'm feeling very lonely up here, guys. It's getting very... a primary care pediatrician at Boston Medical Center. Lucy has distinguished herself in many ways, including of innovating ways at providing tax preparation to low-income families, which she may talk about. Regina LaRocque is an infectious disease specialist at Massachusetts General Hospital, who has dedicated herself to really trying to look closely at the relationships between climate and infectious diseases, so you'll hear from her. Gary, whom I just saw, Gary Belkin is a psychiatrist who has a distinguished career, including being deputy commissioner of the Public Health Department for the City of New York and starting a program called Thrive NYC, which is a program to really innovate mental health care so that it became accessible to all. More recently, he started the Billion Minds Institute and is a visiting scientist at the Harvard Chan School. And Mary Rice. Mary is a pulmonary and critical care doc at the Beth Israel Deaconess Medical Center, and she does research on air quality and respiratory health. And so what I'd like to do is, let's see, I think we have some, you guys know what order you're talking in, or you need cues? No, I'll give some cues. But Gaurab, you're up first.
I'll grab the clicker over here. All right. So it's wonderful to see everyone, and thank you for coming today. I'm going to start by telling you about a patient of mine who had not established care in the United States yet, so came to our emergency room at Cambridge Health Alliance just about a year ago. And so he was a really lovely guy, a 27-year-old male who had moved from El Salvador about 5 years prior, had a history of asthma, and was a sugarcane farmer back at home. He had, was very excited because his wife was pregnant and they were expecting their first child. And he had about a month of URI symptoms, but increasingly was not feeling well over the last week or so. He came in with some shortness of breath, orthopnea, headache, and fatigue. And unfortunately was found to be an end-stage renal disease, which was completely a surprise to him and devastating, of course, to him and his family. After a very comprehensive evaluation, he was come to believe to have chronic kidney disease of unknown origin. Now, briefly, what this is a pre-renal acute kidney injury phenomenon in which prolonged exposure, chronic exposure to heat over time causes repeated injuries to the kidneys such that someone could develop chronic kidney disease, and in my patient's case, end-stage renal disease, without even realizing. Farmers are really in the middle of this, right? He was a farmer back home. It was devastating for him, right? He was completely blindsided by this. It's one of the most, it's a major cause of morbidity and mortality in Central America. And appropriately, in this New England Journal perspective piece, the authors call this an example of the new era of climate medicine. So you're telling me that, well, in Boston, in Massachusetts, we're not seeing much CKDU. Why are you bringing up this patient? Well, it may be true that we don't see that much CKDU, but we see plenty of heat, as Dr. Salas had described. And it made me really think about how much I was thinking about the implications of heat exposure for my patients, particularly those who were working outside, laboring in the heat throughout our very hot summers. And the truth is, even as a primary care doctor who feels like I know my patients, I've developed relationships with my patients, I certainly was not thinking about it through that lens that Dr. Salas was describing. And as Dr. Salas said, the Northeast is particularly warming the hottest in all of the United States. And in the county that I practice, in Middlesex, you can see that our county has warmed to 1.7 degrees Celsius from pre-industrial levels, which is nearly double what the rest of the United States has experienced. I want to walk you through this diagram here, which is from the city of Cambridge. If you look at our baseline on the left side here, the orange, you can see that there's about 10 days of heat over 90 degrees and about 1 over 100. By 2030, that's expected to increase to about 29 days and 2 days of over 100. So 29 days over 90 degrees and 2 days over 100. And then if you come over into the future, 2070, those same colors, you see the expansion of those days. And then the other colors, the orange and the pink, show kind of the worst case climate scenarios. So this kind of brings home how much heat and how much dangerous heat we are potentially exposed to into the future. Now again, heat is, if we look at the ways that heat exposure has implications on our patients, we can basically understand that it impacts all parts of our patient's health. This is a diagram from the Union of Concerned Scientists. Some of the things I think most about is that heat will cause increased heart attacks. It'll increase COPD exacerbations, asthma exacerbations, premature labor, increases the risks of violence, the incidence of violence, mental health disease, anxiety and depression, seizures, strokes. So this is all the stuff that we care about, and we care a lot about protecting our patients, making sure they're doing well. But I don't think I had this lens of understanding the interface of our environment and our patients, of the climate and our patients. I think actually a lot about social determinants of health and the way that poverty and things like that impact my patients, but I didn't have this additional lens of the environment. It's really important for me to anchor this conversation in health equity. So I see Martha here. Martha wrote a piece a few years ago here about the heat islands in Chelsea. And so what is a heat island? It means that instead of having a large green canopy, a tree canopy and green space, many cities, particularly poor cities, have heat islands, which means that there's a lot of concrete and a lot of asphalt. And on these hot days that we're worried about, these dangerous days, these cities can be 10, 15 degrees hotter than their neighboring, more wealthy communities. And so our patients are languishing in particularly hot areas in these islands. This is a study that came out just in about the last few weeks. So this studied the implications of redlining and urban heat. So briefly, what redlining is, it's a practice that was started from federal policy that was established in the 1930s, had explicitly racist language that enabled banks to not provide mortgages and insurance and loans to community of color. Really changed the trajectory of a lot of communities. And what this study showed was that red line communities, there's literally a red line around some communities that banks were not investing into. Those communities were 2.6 degrees Celsius warmer than non-red line communities. Dr. Salas told you a little bit about the implications of just fractions of a Celsius of degree of warming. So now what am I thinking about? And frankly, I'm in the middle of thinking about this. I'm trying to wrap my head around it still as a clinician. But it really, for me, kind of comes back to my job as a social historian, as a primary care doctor, someone who takes a lot of pride in knowing my patients and knowing their lived experience and having a relationship and understanding how they live out in the community. Do I really understand the exposures that are happening to them at work? Do I understand how much heat they're really coming across? Do I know if they're really safe at home, particularly for these very hot days? What does their home situation look like? Do they even have an AC? Am I asking that question? Social connections. Do I really understand the implications of their social connections or lack thereof? In 1995, there was a Chicago heat wave that killed more than 700 people, and the social connectivity was a major indication of who was able to survive that very big tragedy. Does my community have a cooling center? Do I know how to tell my patients where to go on these days? And should we have a registry to help outreach to patients when we know that heat waves are on the way? I just want to make sure we briefly introduce the notion of health co-benefits. That simply means that interventions that decrease greenhouse gas emissions also have a mechanism of directly improving human health. So as a primary care doctor, what do I talk a lot about? Of course, healthy eating. We have to move to an increasing plant-based diet, and that's very important for our greenhouse gas emissions and the health of our planet. It's also a very positive thing for my patients and their health. But we need the right food systems to be able to make that transition. I want my patients to be biking and walking and exercising. Getting out of vehicles is obviously a major part of our solutions for the health of our planet, and it's crucial to our patients' health. But as this study showed, we need walkable cities. We need the infrastructure that enables us to be able to get around and live our lives by not being in cars all day. And of course, we need clean energy. And Dr. Rice will talk more about this, but the particulate matters that come out of these dirty energy sources warms our planet and dirties the air and increases our risks of heart attacks and COPD exacerbations. So while the problems are interconnected and this crisis is deep, the solutions actually impact a number of things that we care about. Just want to briefly make a point that as a primary care doctor that works at a community health center in Somerville, just a few blocks away from our city council, I feel like it's a part of my job to be deeply engaged in my community, to understand what's happening and how a community health perspective will improve my patients' health. I have come to just start emailing my city councilors. Monday, I'm meeting with the mayor of Cambridge because for me, it feels really important for us to get in the middle of this public discussion. There's a lot of misinformation that's frankly really poisoning the conversation out there. And we have the opportunity to engage in a way in which we can be trusted sources of clarity, to put health first, and to make sure that we engage in this crisis. Just gonna end on a personal note. I enter this conversation as a physician, but also as a parent of 2 young children. And frankly, this is a tough issue. It's an emotional issue. There's a bigness to it. There's distress. I'm sure many of you can feel it. And I remember walking with Ari down the Charles River, really talking about my kids a lot. I will tell you that engaging in this issue has been such a source of hope for me. I've come to realize how much there is we can do. And it's been a real, a true source of hope for me to engage in this community so that we can take care of our children. And I'm grateful to see everyone here today doing the same. Thank you.
Thank you, Gaurab. I'd like to turn it over now to Dr. Marcil.
Hello? Hi. Oh, thank you. Okay, so I'm a pediatrician at Boston Medical Center, and this is a picture of an apartment in Puerto Rico after Hurricane Maria. I was working in clinic one night and met a family who had been living in an apartment like this one. So imagine that you're this parent. You are on the 14th floor of this building. You don't have power, you don't have intact windows, and you have young children you have to care for. The only way that you can get down is by walking down 14 flights of stairs. This family had put up with these conditions for weeks. And months later, they finally moved to Boston because they gave up. They had to leave their home. But like any parent, they were not actually that concerned about themselves. They were worried about the impact on their 7-year-old son. They described to me his myriad of health problems. He had developmental problems. He couldn't read. He was having trouble socially. He had asthma. He was gaining weight rapidly. And they were really, really worried about the impact on his emotional health of having lived in these poor conditions for the last few months. They looked to me and said, what can we do? Unfortunately, this is not some dramatic, anomalous story that I'm sharing with you. The WHO estimates that children bear 88% of the impacts of climate change. And yet, like pretty much every other arena in our world, their voices are not well represented in our policy arena. And so it is our responsibility as physicians to speak for them. Pediatrics Children are vulnerable to a lot of different health problems, many of the ones I just mentioned that my patient had from climate change. So as you can see here, there's trauma, both physical and emotional, that children experience from disasters. There are respiratory problems, developmental problems, infections, and malnutrition, both under and overweight. So I'm going to just touch on a few of these, given the format. The first is the trauma. It's estimated that about 175 million children in the next decade will experience a natural disaster. Currently, about 14% of children have. So this is not an uncommon situation. Children are, not surprisingly, more vulnerable to the impacts in terms of their mental health of trauma than adults. They are not in control of the situation. They may not understand what's going on. They don't get to make the decisions about what's going to happen next. They don't have the vocabulary to talk to anyone about how they feel. And this bears out in the data. After Hurricane Katrina, 2 years later, 10% of children still were showing severe emotional effects of that trauma. We might think that these disasters are happening elsewhere, but they're not. The US has experienced, on average, 21.5 events per year over the last 5 years, which makes us one of the 5 most affected countries. Similarly, children are very vulnerable in terms of their respiratory status. Their lungs are still developing, they breathe at a faster rate, they spend more time outdoors and more time engaged in vigorous physical activity. We could all learn from them. They also are closer to the ground, and the way the air pollution divides out makes that a more dangerous situation as well. So we know that there are increasing rates of both pollutants and heat-related pollens. For example, the CDC released a report that said that in 2001, 1 in 12 people had asthma. By 2001, 1 in 14 did. By 2009, 1 in 12 did, but 1 in 10 children did. So they're more vulnerable in terms of their lungs. They're also more vulnerable in terms of their nervous systems. Numerous studies at this point now show that air pollutants, both in utero and after birth, affect neurodevelopment. They affect rates of autism, rates of ADHD, and they affect IQ. These are long-term, irreversible conditions that we can prevent. So how can we incorporate this knowledge of all these terrible, scary, sad things into our clinical practice? Of course, we can talk about being prepared to provide health care during disasters, but there's a lot more that we can do. We need to start talking about it just in general, both to other providers and to our patients, because if people are not aware of it, they can't act on it. And then we need to talk to our patients so they are empowered with knowledge about this situation. If I were a pregnant woman right now and I knew that being exposed to air pollution was putting my fetus at risk of having irreversible neurologic conditions, I would want to know that. And I would want to change my environment to the extent possible to protect that fetus. And there are ways you can do that. There are being developed personal air quality monitoring devices for people with more disposable income so that you can change your morning commute, say, to a lower pollution time. And air pollution is an issue in the US that is impacting children right now. Anywhere between 10% and 50% of children live in areas in the US that exceed the maximum recommended levels put out by the WHO. So this, again, is not something that's happening in other countries. This is happening right here for our children. We also, as other speakers have alluded to, can advocate for our patients. So most of the patients I take care of are vulnerable. This is a picture actually that I took in Bangladesh of a poor neighborhood. You can see it's very vulnerable to flooding, and it's really easy to think this happens elsewhere. This is not Boston, but it is Boston. Poor people in Boston live in neighborhoods that are more vulnerable in many different ways. You just heard they're more vulnerable to heat, they're more vulnerable to flooding, and that translates into difficulties getting to healthcare appointments. It translates into difficulties taking care of their children during weather fluctuations. I just saw a baby this week who's living in an apartment with no heat in the middle of winter in Boston. But as a physician, I can write a letter to a utility company that ensures that the utility company has to provide that family with power. So they can have air conditioning during extreme heat, but if doctors don't offer that to patients, our patients don't know to ask for it. Sorry. So the last point I'll make here is that there's little known right now about what parents want to hear from us as doctors in terms of discussing climate change during healthcare visits. We're actively engaged. I'm involved with some colleagues on doing research to understand this better. But in the meantime, these are points that have been put out that recommend how parents can talk to their children about climate change. And us knowing this is important so that when it does come up and it's relevant, we can provide support in terms of their mental health as well as other factors. So I will pause there, but there's a lot more to say about the ways in which we can protect our children from climate change. Thank you so much.
Thank you, Lucy. Thank you, Dr. Marcil. I'd like to next turn it over to Dr. LaRocque.
Great, thank you. How do I advance these just so I know? Can everybody hear me okay? So I am Regina LaRocque. I am an infectious disease specialist and a researcher, and I'm going to talk to you today about why the climate crisis interdigitates intimately with infectious diseases. I don't think it's a surprise to anybody here that the microorganisms that cause infections in humans exist in ecosystems. They live in soil and water environments. They are transmitted by insects, and they infect other animals. They are fundamentally part of the ecosystem. Oh, that's not good. Okay, how do I advance it? Next one, okay. And we already know, I think, from our own lived experience that infectious diseases relate to seasonality and to climate. Flu occurs in the winter. Norovirus occurs in the winter. I'll just say that my own career began in the field of cholera. And in 1991, cholera hit Peru. And it hit South America with an incredible force. There were 1 million cases of cholera in South America over the subsequent 2 years. And at the time, everybody thought, this seems to be related to an El Nino event that recently occurred. But we weren't really sure if that cholera outbreak could be truly attributed to that climate event. Well, the fascinating thing is now I think we're pretty sure from what we see from large data sets that we can actually predict infectious disease outbreaks globally based on climate patterns. So the El Nino Southern Oscillation is an atmospheric interaction with the Pacific Ocean that leads to predictable extreme changes in rainfall and temperature. And it is also associated with outbreaks of rodent-borne, vector-borne, and waterborne diseases across large swaths of the various continents that you see here. In 2015, there was an intense El Nino, and using large data sets, NOAA was able to predict an association between these two events. So climate is clearly related to outbreaks of infectious diseases. And the ways that climate is in fact affecting our environment are naturally the same things that are going to interdigitate with infectious diseases. More precipitation, more drought, changes in the behavior of insects and animals, mass migration of humans. These are things that are intimately connected to infectious diseases. So I'd like to just tell you a little bit about some of the manifestations of this that we're already seeing. Dengue, which is a viral disease transmitted by a mosquito, is occurring at incredible levels. There were 390 million cases of dengue this year. The rates are unprecedented in South America right now. And the map here shows you the kind of inexorable spread of dengue and its subtypes across the continents over the last few decades. Cholera, which I've studied for many years, we know now has the capacity to live in parts of the ocean where it really wouldn't have existed before due to changing temperature and salinity. Coccidioides is a fungal infection that occurs in California, and there has been a peak in disease over the last couple of decades in association with drought and an expansion of geographic range in California of people seen with valley fever. We know in the last 15 years that we've had a tripling in vector-borne diseases in the United States. And I think here in Massachusetts, we're keenly aware that we are at the epicenter of where Lyme disease occurs. And you can see in our own clinical practices, this is occurring. I think what's worth pointing out is that there's a lot we don't know about these associations as well, and a lot we still need to learn. So there's been some very interesting data in recent years that make associations between temperature and antimicrobial resistance. And those of us who practice infectious disease know that this is the other kind of seminal threat to our health, the fact that we have extensively drug-resistant bacteria that we can't treat in the hospital. The CDC put out its most recent threat report indicating there were 2.6 million infections with drug-resistant bacteria in the United States per year. And there are some very interesting associations between temperature and antibiotic resistance in bacteria. And it does have underpinnings in the bacterial stress response that occurs in association with temperature and other environmental stressors. The other thing is that we don't know what we don't know. But we have seen, and we will continue to see, I believe, emergence of diseases that are new. This is a case that I was a discussant on this past year, Powassan encephalitis, a patient at Mass General Hospital presenting with a rare and unusual, previously unidentified viral cause of encephalitis. We actually now have seen well over 24 cases like this. These are new diseases that we haven't seen before. And in association with the rise of vector-borne diseases in the last 15 years, we've seen 9 new vector-borne illnesses also occur. Now, of course, some of this overlaps with our improved diagnostic abilities, but I don't think it's a stretch for us to believe that climate is a factor as well. So I think the implications for clinical practice for infectious diseases are really first just understanding where we are in this picture. So this is the parable of the blind men and the elephant, each of whom feels the elephant at a different point and has a different understanding of it. And I think that a lot of the time, you know, we're this guy here at the tail kind of feeling one piece of the story, but it's important to step back and see what we see in our own clinical practice as part of a larger picture that is emerging on a global scale. So what does that mean for us in our practice of infectious diseases? Well, I always think about things first from a public health perspective and then from my own clinical practice. And I'm hoping we get into some of these conversations here. But I'd like to just give you a few of my thoughts. From a public health perspective, it's good news that we're beginning to talk about this idea of One Health, or the idea that a healthy human is also a healthy animal, is also a healthy planet. And these are a lens through which we can look at many of our infectious disease problems, and we should be doing that. We need more infectious disease doctors, people who are thinking about identifying, describing, and reporting new diseases so that we can understand this better. And I like to underscore the fact that being good stewards of the resources that we have now is also a way to protect us against this very problem. We've talked a lot, and we will talk more about environmental degradation, and I just want to point out that we have a real problem with antibiotic pollution in the world as well. So over 30% of rivers in the world, you can detect antibiotics in them. So I'll just point out, being stewards of our resources from a public health perspective is important. And what do we do in our practice? Well, I think a couple of things that come to my mind are that we need to expect the unexpected. We need to look and be aware that infectious diseases will occur in places we may not have seen them before, or in settings we may not have seen them before, and be alert to the possibility. We need to take good histories. We need to ask people about where they've traveled and what their living circumstances are and what they've been exposed to. And we need to think about changing seasonality and geography. And I think it really boils down to focusing a lot on the fundamentals of infectious disease, which is preventing illness, hand washing, respiratory etiquette, making sure that people know how to avoid insects. These are key messages we need to be sharing. And I will also point out that I think some of this interdigitates with our problem of trust in vaccination, because vaccination is going to be the one toolkit in our armamentarium that we'll need to deploy, and we need people to trust us on that front. And lastly, I just always underscore that we need to remember that some people are more vulnerable, and we should be protecting them the most as we think about this in practice. And And I just want to end with a little bit of a story, you know, which I think as we move back to this notion of thinking about One Health and how our actions in our clinical practice interdigitate with the climate crisis. You know, I think about what we experienced this summer in Massachusetts in the case of EEE, which I think induced a tremendous amount of panic in our communities. And when you have panic, you have a political urgency to do something immediately. And you may know that we had aerial spraying as a response to this. You know, the clinical benefits of that I think are questionable, but I would say that maybe as we begin to look at things through a broader lens, we might want to reflect on the fact that we're experiencing a decimation of the insect population now, and that maybe we have a different responsibility as we make decisions about widespread aerial spraying, if that's really the best way to protect the health of us and the health of our environment. So I think one message I'd like to share is make sure we don't make things worse as we respond in our own practice. So I look forward to some very exciting conversations on these topics.
Thank you, Dr. LaRocque. Next up, Dr. Belkin.
Good afternoon, everyone. So I'm here talking about mental health and climate change. And, you know, we know an awful lot about how extreme weather events markedly escalate PTSD, depression, suicide, substance use, violence. But we need to know a lot more about the growing roster of ways mental health operates and is relevant to clinical practice outside of extreme events, which is a growing body of skills that we should all have and be familiar with. I'm going to focus on two issues of that growing list. One is heat risk and mental health, and another is how we all are part of addressing what will be a growing background degree of population-level psychological distress. So heat, we know that heat makes all mental illness worse. It actually increases emergency room visits, psychiatric hospitalization rates, worsening symptoms across the spectrum of diagnoses. But we also know that mental illness is potentially one of the largest predictors, if not the largest predictor, of death in heat waves, having a mental illness. This is meta-analysis summary. These are the ORs, thank you, odds ratio profiles for mental illness as a predictor of mortality compared to for cardiovascular illness or underlying pulmonary illness. Another big predictor, though, is also being on a psychotropic medication, and that's as a predictor of mortality. And that's largely due to these particular suspects, anticholinergics and antipsychotics, which mess with thermoregulation and, how could that be? 5 minutes? Okay. Risk for heat stroke and SSRIs, which cause SIADH and affect water balance and hyponatremia. And obviously dehydration is a big risk for lithium toxicity. There's more data across time and geography that there's a clear dependency between increased monthly average heat and monthly average suicide rates seem to co-vary. The takeaway from all of this is that in our mind's eye of who is fragile in our practices when it's hotter, front of mind should be people with mental illness and people on these medications. So in the skill set and in our habits of work have to include that association and that context. But we also have to include in the normal practice skill set being part of addressing what will likely be growing background psychological distress. We're just starting to get our hands on that empirically. In the popular culture, there's more discussion of things like climate anxiety, ecological grief. We have polling data, which you see that actually show a marked and recent shift in public attitudes a majority of Americans now think they're either alarmed or concerned about global warming. This is a flip of a scale of worry in the last couple of years. A colleague of mine, Susan Clayton, has some personal communication data. We're just starting to get more empirical data that she shared that actually tries to put a quantification of the emotional morbidity on that concern. and finding very high pluralities of people endorsing that that concern translates into things like daily impaired concentration, loss of sleep, inability to enjoy things, and so forth. We really have to understand how far and deep this background distress goes, because I think it goes pretty far. I think it goes especially far in our youth, and we really have to understand that. I hear reports from clinicians of everywhere from peer pressure to declare that you will not have children when you grow up, to case reports of psychotic depression, of teenagers afraid to drink water because they're contributing to drought. So we really have to understand what's happening to this generation. And all of us as clinicians can be part of owning a toolkit to both counsel youth and parents, and that was brought up earlier, but also to broaden our toolkit of helping people with this anxiety. We have to really break this barrier that only the psychiatrists, only the mental health folks own these sorts of behavioral skills. There's a growing literature on on primary care settings as a place for mindfulness methods. I recommend this book, Transformational Resilience, among a lot of manuals coming out that really give a 101 version of trauma-informed methods and activities that can be done by anyone. This is actually meant for lay people, so I think internists can also handle it. Just controlled breathing, gastroenterologists. Just controlled breathing, we know resets normal cortisol levels and can have a sustained impact on reduced, this is the uninterrupted lines before and after versus controls, really substantial reduces in cortisol as well as symptom reduction. These are skills that we can teach each other, we can certainly teach our patients, and we're going to need it. I really think we're going to, we know from other adverse community situations that when there is a high burden of psychological distress, social cohesion unravels, collective efficacy unravels, and as we touch so many people, we can help them through that. For those of you who want to refer people, there is a growing network of climate-aware therapists at climatepsychiatryalliance.org and climatepsychology.org. I would like to close. I've added to my habit and toolkit to get arrested. That's me. And before I left for this action, I was telling my 4-year-old son why he might not see me for a while. I said, I'm going to a protest. What's a protest? Well, a lot of us are really worried that the earth is breaking, and we want to get attention to that and have people try to not make that happen. And so he said, the earth might be breaking, then you should take my magic wand. And it was very touching. I took it. It was not very imposing. It was a tiny stick. But we don't have a magic wand. We have each other. We have our skills. We have our commitment to bring those skills into our offices and perhaps some of us into our communities. And that's what's going to change things. And I thank you for your attention.
Thank you, Dr. Belkin. Dr. Rice.
Thank you, Ari. So I am a pulmonologist and an air pollution researcher, and I think about climate change through the lens of air quality. And I'd like to take you through some of these connections and how it affects our patients with lung disease. One of them is ozone smog, a form of air pollution that can be a significant problem here in the Boston area, and how that's affected by climate change. The other that we've already touched on is pollen. Wildfires, while not as big of an issue here in Boston, is certainly a big issue for patients across the country. And I'd like to end with a discussion of the connection between fossil fuel burning, climate change, and air quality. So ground level ozone is not to be confused with stratospheric ozone. What I'm talking about here is a component of photochemical smog. It's ground level ozone that is a secondary pollutant, which means that it's formed through chemical reactions from VOCs and nitrogen oxides that are released by traffic, power plants, and other forms of fuel combustion. It's a very powerful oxidant, and it is a very well understood respiratory irritant, so associated with respiratory hospitalizations, asthma admissions. And the formation of ozone is enhanced in the setting of higher temperatures. So as we experience hotter summers, there's very strong evidence that ozone levels increase. It's actually, there's many models predicting a substantial increase in the number of ozone events as a result of the higher temperatures that we're experiencing, and that includes the East Coast here. And here's just an example of the association between ozone exposure and asthma admissions. If you were to look at studies across the country, you'd again see this very linear relationship between ozone exposure and hospitalization for asthma. Ozone's also associated with premature mortality. So here is the current EPA standard of 70 parts per billion, and we see linear associations across the range of exposure that we experience day to day, even within current EPA standards. The pollen season is very much affected by climate change because plants bloom earlier in the spring when it's warmer, and the ragweed season lasts longer because it ends when we experience the first frost. And so this is EPA data that's actually no longer on the EPA website. But it shows the change in the ragweed season that we've experienced from 1995 to 2013. And here in the Northeast, it's about 2 weeks longer than it was in the 1990s. So that's a substantial lengthening of the season. And the amount of pollen that's produced is also enhanced in the setting of higher CO2 concentrations. So you might say, oh, pollen, allergies, it's not really such a serious health problem. Well, about a third of the population has allergic rhinitis. So we're talking about a lot of people being affected, having a pollen season that for some can extend from the early spring all the way into the late fall and winter. And it's associated with symptoms, missed work days, missed school days, asthma attacks in kids and adults. So I would say it's actually a pretty substantial public health issue. Each degree of warming dramatically increases risk of wildfires. And even though we don't experience wildfires here on the East Coast, that smoke really travels. So this is just an image, a satellite image of one of the California wildfires in 2017. And you can actually see the smoke extending all the way across the country. And when the EPA has a system for accounting for where the particulate matter in the atmosphere comes from, about a third of the particulate matter in the US that is emitted each year is emitted from wildfires. So it is a major source of the particulate matter that we're exposed to. And this picture really alarms me. So I study the health effects of particulate matter. Generally speaking, the US is a great success story in terms of air quality. Our regulations have tightened over time. The amount of particulate matter emitted by motor vehicles has really gone down. And as a result of that, we've experienced major public health benefits and major improvements in air quality across the country. But that's not the case in wildfire-prone parts of the US. We've actually seen a degradation of air quality since the 1980s, which is crazy. And I think that the health effects of wildfire exposures are really easy to study. You can look at hospitalizations before, during, and after, and wildfires are associated with asthma admissions, other forms of respiratory emissions, COPD, pneumonia, and also cardiovascular health effects like heart attack and stroke. And I'd like to end with a discussion of this point about what is the ultimate cause of climate change? Well, it's our dependence on fossil fuels for energy. Right? And what do all these pictures have in common? Audience participation. What's going on in every picture? Combustion, right? Burning of something, burning of fuels. And when fuels are burned, gases and particles are released into the atmosphere that make people sick. And so when we combat climate change, not only are we addressing all of these many health issues that we've been talking about, we immediately clean up the air, and that means that people are healthier right away. Right? There are health benefits that are immediate for our kids and for our patients. So it just makes sense to move away from our dependence on fossil fuels. So what can doctors do? here's a list of 3 things. We could think of a longer list, but I think we should be talking to our patients about this. I think we should be talking to our hospitals and our clinics about where they get their energy from, and also talking to our representatives. But here we're focused on talking to our patients. Here's yet another shout out to Martha Beebinger of WBUR. This is a piece that she did. This is me with one of my patients. An example of how we can talk to our patients about these issues. So this patient has allergic asthma. She also, her symptoms are also triggered by exposure to air pollution, like the burning of fuel oil for heating and from fireplaces. So how do I talk to her about this? Well, a clinic visit's only 20 minutes, right? You don't have a lot of time. But I think, just as my patients with COPD who aren't smoking anymore might say, why do I have emphysema on my CAT scan? Why are you telling me I have COPD? Well, it's because you used to smoke. That's probably the main reason why you have this problem. Well, I think the same applies to climate change. Just inserting that sentence that your allergies are, one of the reasons your allergies are getting worse is because the pollen season's worse than it used to be. And that's because of climate change. And just getting over that feeling that it's a political topic or a sensitive topic, I think is the first step for us as a community. And then as a pulmonologist, there's some real practical things I can advise her, like looking at the EPA Air Quality Index, looking at pollen indices to help predict what days might be worse for her, things like getting air purifiers in the home. And for my older patients who are really sensitive to heat or to smog, thinking about how we can still get our patients outside and exercising in the setting of these changes in our climate. Thank you.
So now we're going to turn it over to a panel discussion. And I believe some of you, hopefully all of you, saw a link that you can go to at registration to submit questions, which will appear here. So this is a participatory event, so if you have questions, please submit them. And while those come in, I'm going to start, just kick things off. And I just want to thank all of our panelists. For anyone who's been in the position of trying to plan a panel, you always have the sort of jitters as to what really is going to happen when that panel actually speaks. And I can tell you that, and I would expect that Renee and Karen would agree with this, we could not be happier with the conversation and the presentations that just happened. And so what I'd like to take advantage of is the fact that you all have spoken so clearly to your backgrounds and your particular disciplines, and I think everyone has a microphone now. Lucy, it's one. I won't need one much, so Gaurab, you can borrow mine. So the question I want to pose to each of you, and we can just go down the row, maybe give Mary a break and start with Regina, is we're here at a moment in time where we're saying it's time for clinicians to step up and really think hard about what climate change means to our practice and to speaking about, speaking to our patients about it. And I would just want each of you to take a minute and think about, as in your, field of medicine, what would be the thing you would tell a colleague about that who was sort of on the fence, who was looking at you, someone you've known for a long time, and saying, I think climate change is a big deal, but I'm not quite sure as a provider what my responsibility is to this. Now, I know some of you addressed this in your remarks somewhat, but I just want to nail that on head, because part of what we're trying to do here is to figure out how to talk about this among our colleagues, because as many of you may know, in the medical community, not everyone necessarily sees this as a challenge that should be addressed within the medical community. All right? Does that sound fair, Regina?
So I'm not allowed to ask you to start on the other end? So can you repeat the question?
Yeah. The question is, if you're talking to a colleague who's a fellow infectious
Right.
disease doc who, let's say, was saying climate change is caused by humans, and it's a big problem, but I
Right.
don't necessarily see, as my role as an infectious disease doc,
Right.
why I should be interested. It's bad for infectious diseases even, right? I hear the argument that it may be spreading dengue, cholera is affected, but what would you say to that person in terms of how they would think about their job as an infectious disease doc?
Got it. I think the most important thing we can do as infectious disease doctors is to actually just name the fact that these two entities are associated, because for, I would say too long, we've been hesitant to admit that this association clearly exists. There's lots of other potential confounding factors. You know, we have improved diagnostics, people travel internationally, there's other human behaviors that affect insects, but we've been loath for too long to just put out there the rather obvious fact that climate and weather are one of the other factors that are driving this expansion of infectious diseases globally. So I think just talking about it with our colleagues in professional settings and in, you know, I was a discussant on that case of Powassan encephalitis, but I was the one paragraph at the end where we talked about why this might be a reflection of climate in our clinical practice. I mean, I think that our tendency is to talk a lot about the new diagnostics and the management, and then, oh, by the way, this might be climate. So maybe the other thing we need to do is flip that emphasis a little bit too.
Yeah, I think that, there are two things I think about. One is blame and one is stigma. So a lot of health problems, as a primary care doctor, we're at risk of inadvertently blaming our patients for. So an example of this that I didn't talk about would be obesity. There's some data that show if you live near a highway, which means you're exposed to higher levels of air pollution, you're unfortunately at risk of being more obese as a child. And we think that that is actually from the air pollution in part. And yet I have conversations all day long with my patients about how they need to choose healthier foods and exercise more. And if I don't share with them, well, you live in a poor neighborhood of Boston that's by the highway, and so actually part of this is out of your control, then I'm blaming my patient and making their care worse. Patients feeling blame is linked to decreased adherence to care, and of course, poor mental health impacts. And then the stigma issue, you know, I think someone else alluded to this, but the Yale Climate Communication Project has found that 2/3 of American adults do believe climate change is happening right now, but only 1/3 of them actually talk with anyone about it. And so I think it's just like any other sensitive issue in healthcare. Think about sex or mental health. We don't talk about it. We send the message to people. It's not okay to talk about it. And we are, for better or worse, revered members of society that people look to set the standard in terms of what's okay to talk about. So just like I talk to my patients about money and taxes, I think we also have to talk to them about climate. And that's what I would tell a colleague.
Yeah, I think this comes down to a conversation of how we define our professional responsibilities, right? And that's a tough conversation because we take a lot of responsibility as clinicians, and we have tough work, and we do a lot. And we are asking people to take on more responsibility. But I do think it comes down to that. I had just this experience maybe a month ago. A colleague of mine walks down the hall and said, I've been seeing so much Lyme these days. And I said, that's because of climate change, you know. And he raised his eyebrows and was like, what are you talking about? Now, you know, the truth is I have sympathy to that because I think even a couple years ago, I didn't get it. And I think once you can see it, it's hard to unsee. And there's a lot of people for a variety of reasons that have not been able to see it. Once I was able to see it, it activated me. And it's a lift, and I guess we're asking everyone in this room to try to be a part of this work of asking our field to expand their sense of professional responsibility and to really root in the values of what we care in our profession to make sure our patients are doing well and thriving and healthy. I think there is no more important factor of how we engage in the climate crisis, and I think it's something our profession can, must, will take on.
I've been struggling how to bring the mental health community along and communicate this in a way that they really see this as front and center to their work, because it challenges a central paradigm of mental health work, which is very office illness based and really isn't connected as healthcare is getting to be connected to social determinants and kind of a ecological model. So it's great when there are examples of the earth as a risk factor that rivals other risk factors that resonate. So there's recently a study where London kids longitudinally followed age 12 exposure to pollution predicted age 18 risk of mental illness that was greater than age 12 exposure to physical abuse. And so that's something, especially with kids, which is probably where mental health folks do get more of the social, ecological kind of picture of things, where the earth becomes a risk factor, the earth becomes an actor in a very different way. The other tack that I think is crucial for the mental health field in our future is the opportunity to the field that opening up to this reality can actually provide in doing things differently in ways that we've actually secretly wanted to do differently. We've wanted to get out of a model of sitting in office visits and waiting for sick people to come to us. We haven't gotten paid for, articulated, or fueled a way in which we are actually partners with skilling up and empowering community members to own their own mental health. A climate future demands that, or we will be, as psychiatrists and mental health providers, less relevant to that future. So that is actually an opportunity vista of necessity driving exciting innovation as another way to try to galvanize this with that community.
I would say another thing we're up against with our colleagues is that almost all of us are trained in the sciences in some way. I mean, we're all essentially scientists, and yet climate change for many decades was treated as a fringe issue, even though the science has been so strong for so long. I mean, the greenhouse gas effect, the fact that carbon dioxide warms the atmosphere, that was first described in the 1800s. I mean, it is well known that greenhouse gases warm the atmosphere. And yet, even those fundamental issues have been questioned even until this time. And so I think as a doctor and a scientist, when I talk to my colleagues, I feel this sting sometimes that I'm talking about a fringe or fluffy issue when it is just not, right? There are things that we do in medicine that have much less science to back it than the fact that climate change makes people sick. And so I think one of the things that we have to do as clinicians is get over that stigma and be confident that the science is strong.
All right, so you all have been typing away furiously, and I'd say there's about 40 questions here. So forgive me for not being a speed reader, but I will do my best. One question here, which I think this panel might be well positioned to address, is a question about medical students. And the question comes from Kate, who asked, what would you want medical students to learn about climate change? You don't all have to answer this one, but if anyone wanted to step in, please do so.
I have a comment on that one. I mean, I think we've done a profound disservice to medical students by not including this in their curriculum to date. It has really been profoundly neglected, and I think Renee alluded to that when she kicked us off here. So I think that, yeah, we need comprehensive education on environmental exposures and health, which I think are neglected to begin with, and I think climate curriculum needs to be developed, and we haven't gotten there yet.
I'll just add, I mean, as someone who does medical education and kind of health equity work, students are demanding it. So it's kind of not really a negotiable thing. I think it just has to be interconnected in each piece of this. So when we're looking under microscopes, we need to be explaining it there. I don't think climate change is this thing you do off to the side. It needs to be a lens that's integrated into everything that we talk about. The work I do is in health equity work. I think it is a fundamental root cause of all of it, right? So I think we need to learn how to integrate this into our, again, this new era of climate medicine, integrate it into our whole vision of what it means to be a good clinician and to provide a healthy society.
Anyway, if I could just add, I've been working mostly with residents in psychiatry who I think also prove the point that they are there. They need leaders. They need us to fuel them. And I think that mirrors the larger societal potential of a real generational divide that could be very destructive, where our youth are there and in some ways suffering the most, but we're not there with them. And we really need to be. And whatever that is at a metapsychological level, of our own guilt or unreadiness, we have to rise up to that, whether it's in our educational systems or in our communities.
So we've gotten a couple questions here about blowback. So let me try and paraphrase them. There's about 3 or 4 of them, and some of them relate to statements about attributing, for example, Lyme disease and climate change. So someone might say, well, Lyme disease is largely because we're building in the forest where the ticks are, and that's why we have more Lyme disease. Or many of you will be familiar with pieces in the popular press about medical education, and we shouldn't be talking about climate change in medical education. And so the questions are, one, have you experienced that in potentially talking to a patient or a colleague? And if so, how have you responded? How do you work through that?
I guess I would say that as someone who works in health equity, which is a very complicated area of study and very difficult to ever prove direct causality and tease out all the multitude of effects. This is something that I run into in general with my work of colleagues who are trained and speaking very carefully at all times, feeling uncomfortable. And honestly, I think that it's a matter of ethics to say that, yes, we can't say that all Lyme disease is because of climate change, but we know that this is a factor that is increasing climate change, and I have a moral duty to speak out about it. I can't wait another 20 years for the scientific evidence to build up to tease out that exact pathway, because the climate will have changed by then. And so I think that we have to change our profession and our comfort with pushing the envelope and being a little bit more activist and a little bit less in our own heads and labs and studies.
And it also, we haven't brought up in this conversation, we talked about climate, we haven't talked about sustainability. And as you go down the climate path, you get into these even more difficult issues about changing lifestyles and cultures and how we eat and how we live and where we build homes and where we encroach on nature. And so it is part of the Lyme disease story. Why are we building there? And that's when it gets to be a messier conversation, and but one that we at least need to start.
Oh, I was just going to draw attention to the issue of causality that you were talking about. That there's often this question of, well, is that hospital admission due to climate change, or is that specific hurricane due to climate change? And I think we can talk about trends without having to put ourselves in the spot of attributing a specific hospitalization to climate change. There's plenty of data to support the trends, and there's plenty of data to support the associations between trends like wildfires and hurricanes and what happens to human health. So I think there's enough there for us to be comfortable talking about causality without getting into the trap of what you were talking about with doctors wanting to be really precise about saying that one thing is due to another. And I think that's what we grapple with a lot in these conversations about climate change.
I'd like to add one point to that, which is I think what we're all getting at is that the notion of ourselves, putting ourselves forward as physicians and trusted members of society and talking about this is valuable in itself. And I think the reason it's valuable is because there are concerted efforts to confuse people about the science and the links that are known. And so we are feeling that also. So I think we at this point in the kind of transformation of the community conversation on that, we might be putting ourselves out a little bit professionally to talk about this, but that's probably because there are efforts to undermine the science. And so it makes it all the more important that people like us are willing to talk about these concerns publicly.
Sky, can I get a time check? We got time. Good. All right. So next question comes from Anonymous. In thinking about how clinical practice can meet climate crisis needs, what can hospitals and healthcare systems do to make it easier for clinicians?
We should have a whole panel on that. Maybe have some hospital leaders. I think this is one of my reactions to the bigness of this is let's just look in front of our nose and try to decarbonize what's in front of us. So I'll tell you, at our hospital, we have a little ragtag working group that's trying to engage our hospital. And I know those efforts are around everywhere. So I think that sometimes, again, I'm really, I think it's really important us to engage in that spot where it feels like this is too overwhelming. I'm very busy. It's big, and today the weather is fine, and I have someone suffering in front of me. I think that there's a human psychology that makes it hard for us to grapple with the totality of this crisis because of its bigness. And I think a solution to that is to look right in front of you and try to engage your immediate community as a private citizen in your community and as a citizen of your hospital. And so I'll tell you, my experience has been once we opened up the door, we did a grand rounds, and then we had some folks working on it. The floodgates really opened up, and our engagements are, this is something that is very much on people's minds, and I think it just takes that activation energy to get the ball rolling.
I couldn't agree more. So I work at Beth Israel Deaconess Medical Center, and over the last couple of years, I've become increasingly involved in talking to hospital leadership about climate change in health and air quality in health. And the folks in hospital leadership and facilities, they're not expecting doctors to knock on their doors. And once I started having those conversations, the dialogue, just as you described, really opened up. People were very receptive. Is Avery Pilardi in the audience still? Or maybe she ran off to something. Hi, Avery. So, Avery, this happened sort of before you were recruited, and there was more energy and enthusiasm for our sustainability work, and now our hospital is really expanding the work that they're doing for sustainability. So I think as doctors, there's this unique opportunity, or you could say a responsibility really, to talk to our institutions about how our hospital operations affect health. And we bring a unique perspective to those conversations, I think.
Could I just say one more thing? I think also, as a doctor or clinician, we think we got to be the one that fixes something. I don't know how to decarbonize a building. I'm not a facilities person, and we really need to focus on teamwork here and know what we bring to the table and create a team where people are working from their access point to do this work, and we don't need to fix it by ourselves.
And imagine how powerful it would be if large health systems, the Harvard system, hospital systems, became advocates for community action on climate. The UK NHS wrote a report about turning that health service into an anchor institution. The notion being that there are various civic institutions that have permanence and presence and credibility and great purchasing power, logistical power, managerial, intellectual, actual capital that can be part of other community projects, either as an organizer or a driver or a platform that actually get at social determinants and other aspects of health, with climate and sustainability action being high on that list. We have unleashed power to enable our communities to go through and work through climate transitions if we applied the fullness of the tools that we bring to that.
I think it's worth acknowledging the years of work of Healthcare Without Harm, some of whom are here, who've really been leaders on turning our healthcare systems into more sustainable entities. And I'm really proud that at Mass General Hospital we've taken the same steps that you guys have taken. And I think clinicians engaging with people who run buildings and do purchasing and supplies, it's kind of an exciting thing.
So I'll just add that Boston Medical Center is, I believe, on track, if not already, to be carbon neutral by 2030, and is part of this healthcare anchor network system where I think, especially when we're talking about vulnerable populations, we have to, as you said, acknowledge that, if we don't address health in the community, we're actually not doing our jobs, even though it feels maybe better to stay in the clinic and feel like that's where our responsibility ends. Unfortunately, it's not. And it's made me think, too, on a personal level about how we also have to think about our own lives and the examples that we're leaving for our patients and as a profession in terms of our carbon footprint. And I think there's a lot of work to do there as well.
Excellent. So many of you asked questions related to hospital leadership. So I want to point out that our second panel will be filled with those folks. So I'm not going to ask those questions now, but you should ask those questions. I think this group, we want to focus on some clinically relevant, or at least focus on the clinicians we have in front of us. There's some interesting questions here about formality, what I would call formalities of practice. So one person, let me see if they were anonymous or not. Yes, Rebecca said, do you think there's ever going to be an ICD billing code for climate change related health effect? Some people ask about whether we should be including questions about climate risks on our board exams. And I think actually there may be one or two boards that are considering this right now. Should this be on medical student board exams? Is this a good pathway to do some of the things you all were talking about? You know, we have to talk about it. We shouldn't be afraid about talking about it. What do you all think?
I mean, I think if you use the analogy of the social determinants of health field, we now bill for homelessness. And that was not something we did when I was in medical school. And it is part of the path towards, in the ACO system, getting health insurance providers to reimburse for social problems that we know are more expensive to take care of and lead to health impacts. So I could see there being an argument, a similar argument for climate, that if it is part of something we're billing, then people will take it more seriously, and that will be taught within medical education in a way that if there isn't that financial incentive, it might continue to be thought of as a fringe issue rather than something that is actually part of medical care.
All right. Here's a question, I think, also from Anonymous. Some of you talked about the catalytic role that clinicians can play in getting their institutions to do stuff as regards to sustainability and how there's been reception. But this question gets into more detailed, which is, what is the best role of a clinician in terms of decarbonization itself? So is that stepping forward and talking to leadership? Is it something else?
I mean, I'm really drawn to this role of being an explainer. I think that at the heart of our job is taking complex science and making it relevant to people's lives. This is a threat to all the things we care about in this room, right? And we're all very different people. It's a threat to all the things we care about. But this access point of processing the information and the science and then explaining it in a way that matters has been taken over by kind of malignant motivations in a lot of situations. And I think that's the spot for me that you know, primary care doctors, nurses are top trusted voices in this role as explainer. And so I you know, whether it's you know, we went to our CEO and tried to explain it in terms of what matters to us. And I think we do community gatherings at my home actually every few months and have some speakers come over, and the frame there is as parents. So what I've been drawn to is using the role of explainer, understanding what matters to a group of people and translating it so that we can understand how it will matter to that group.
I think the other way that it can play out too is that we can help people feel less paralyzed. You know, there's a lot of feeling like I can't change this, it's happening, even if I never consume another ounce of carbon in my life, this is going to happen. But for instance, I've been thinking a lot about the census this year and how undercounted so many of our children are and our vulnerable populations. And if we can link clearly during a clinic visit to say, hey, your asthma is worse in part because of climate change, and if we make sure that there is money allocated for you and for our district, then we can have policies and politicians in place who might be more likely to protect you. So all you have to do is fill out this survey. That's a very discrete, quick action that could be very empowering to someone who doesn't have a big voice. And so I think we have to think of creative ways people can make concrete change and not just say, this is a problem you should be aware of, but help it become actionable.
I mean, I think one of the problems with people's understanding of climate crisis and environmental degradation is they don't necessarily see it in their own lives. And so I think, like what Gaurab is saying, that our capacity to bring some immediacy, some sense of personal involvement in the topic for people is really key. And I think that's one of the most important things that we offer as physicians talking about this.
All right, last question. And hopefully everyone will get a chance to chime in on this one. What is one clinical practice improvement that you can do tomorrow that adds a climate lens? Let's say it again. What is one clinical practice improvement that you could do tomorrow that adds a climate lens to your work?
Well, I've already made this point, but I think trying to insert the conversation into the clinical visit, to change the dialogue so that patients can start seeing these connections.
Train an environmental justice group in mental health skills.
I'm really drawn to really being able to picture what people look like in their homes. The heat, one point I didn't make during my presentation is that during these heat waves, a lot of it is that it's not cooling off at night. So at nighttime when people are sleeping, it's more dangerous. So I think a clinical practice is really educating people to really understand what it looks like at home for people.
And I think similar to what I said earlier, validating for patients that some of these bad health impacts they're seeing are outside their control because they are related to climate change can be hugely therapeutic and is something that doesn't cost us much time or energy.
I'd love to have a prescription for everybody that I could hand them. Here's my climate concern and here's my prescription for you. I could have one about insects. I could have one about clean air. I could have one about driving an electric car. Why not burning oil in your home is better for you. I think education, but quick and easy.
Drs. LaRocque, Marcil, Basu, Belkin, and Rice, thank you all very much.